Happy New Year. It's Dr. Shelly with HETV. And you know, I was thinking about changing my name and I need y'all's input. What name should I change it to? It's HETV now, Health Education Television. Maybe I'll just leave it. I don't know. It's a new year. I got new plans. But right now, you need to pass a HESI, you need to pass an ATI, or you need to pass an NCLEX, and I got you, boo. I got you. So new this year, like literally hot off the press, is the fact that I have a new playlist. Now, if you know anything about HETV, you know that the entire channel operates by playlist. In other words, when you come to HETV, whatever you have a test on, and in the case of NCLEX, everything that you have a test on, everything is under the playlist. I'm the only reviewer, the only YouTuber, the only RN, the only advanced practice nurse, the only crazy person on earth to put their entire nursing school on YouTube for free. Yeah, you don't even have to pay. So this playlist that I have created for 2025 is your favorite. Select all that apply. So what I'm doing with this playlist is I'm putting in the most common select all that apply videos so that you have a good reference point. And this video behind me is a really common select all that apply. This select all that apply is exactly opposite of the select all that apply that I did yesterday. Yesterday was fluid volume deficit or dehydration. Today's is going to be fluid volume overload or excess. So let's start, shall we? Here we go. Select all that apply. This select all that apply video is on fluid volume excess, which is another word for fluid volume overload. Said another way, hypervolemia. Said even another way, fluid retention. Y'all good? That's not bad. You've seen those before. They're on every test. They're on HESI. They're on your finals. They're on your ATI. They're on your NCLEX. So whatever you need to know on these tests is right behind me. So what I want to show you is when I talk about select alls that apply, I'm literally looking at select all that apply for risk factors. What's a select all that applies for the causes? What's a select all that apply for complications? What's a select all that applies for nursing care? What's a select all that applies for, and let me write it, signs and symptoms. So in other words, no matter how you bring this issue of fluid volume overload, we're going to show you all the select alls I could possibly think of that have been on the test. Now, remember the rule. Remember, when I show you a chart like this, it's a comparison and contrasting chart that usually has the condition I'm teaching about compared and contrasted with the exact opposite for the purpose of your case studies. You gotta know how to study. This behind me is all called content. If you think you can pass your NCLEX just with questions, think again. So this is some of the common content on lots of tests. So let's look at the select alls. And the select alls for risk factors is kind of easy. It's the same select alls we see in the other video that I just did yesterday. So the select all that I did yesterday was risk factors for fluid volume deficit. Now let's take a look at risk factors for fluid volume overload. Of course, it's the same, you guys. Elderly. The elderly patient has a lot of difficulty with fluid balance. In terms of fluid volume deficit, they don't have the thirst reflex. With fluid volume overload, there may be some organ dysfunction, even mild, whether it's kidney or cardiac, that really has the elderly patient having a hard time removing fluid from the body, right? Because as you know, the heart and the kidneys and the liver are very involved in removing fluid from the body. It could even be certain medications that this patient is taking. As you know, steroids make you retain sodium and water. And so you want to really kind of think outside the box and always keep your pharmacology hat on. And that's just why elderly are at risk. But then get this. Babies are also at risk. Their body is 80% of water. It doesn't take much to tip them over the overload edge. And let me give you an example of what could cause a baby to become fluid volume excess or have a fluid volume overload, because that's so weird. Like, what's this baby doing? Like, seriously, the baby's heart is excellent, the kidneys are excellent, the liver is excellent, it's brand new, hasn't had alcohol, didn't have a big old cheeseburger with bacon on it. I like it. Didn't eat a lot of sugar and cause diabetes or anything else. So like, why would a baby be at risk? Well, listen to this. And I want you to spread the wealth, right? Because as nurses, we know that education is power. And tell everybody you know that a baby does not need water before 6 months. No. And when we give babies water before 6 months, we tip them into the overload, or in this case, water intoxication balance. I mean, they really get into trouble. And so a really, really sad story that happened right here in Cleveland, Ohio, during the recession of 2007, 2008, a really, really sad story, is that a lot of people in 2007 and 2008 lost their jobs, lost their homes, cars were repoed, life really sucked. In fact, due to the mortgage fraud, my mortgage that was, around $1,200 a month shot up to $2,300 a month for no good damn reason. Like, I have a fixed rate. Like, what was that about? Thankfully, because of what I do and how I do it, I was able to handle that. But later down the road, I found out it was mortgage fraud. And then when President Obama was in office, I got all that money back. Those regulations have since been destroyed. I couldn't get my money back if that happened again right now, just so you know. Regulations sometimes help. But anyway, I'm off subject. So the bottom line I'm trying to get across to you is that even yours truly had a really hard time in 2007, 2008 because of the mortgage fraud, because of the recession and all the horrible things that were happening during that time. Sort of like your version of the pandemic. This was called a recession. Pandemic was much worse because we lost lives, not just houses and cars. So this patient who had a brand new baby, her husband lost his job. She's got a brand new baby. And I don't know if you know what formula costs, but that powdered can is about $40. It ain't even gonna last a whole week for most babies. And it's very expensive. So this precious, precious mother thought that what she would do is she would kind of water down the baby formula. So instead of putting a certain amount of powdered formula to make her baby's bottles, she would put just a little less powder and a little more water. Yeah, her baby almost died. What did that baby have? It had water intoxication. Another way to say it for this baby was hyponatremia. Another way to say it for this baby was SIADH. Y'all got me? You know this. So I'm bringing up very familiar terms, but I like to give you real life scenarios to help you understand, oh yeah, babies are at risk for water intoxication. So no baby gets water, like none get water before 6 months. Breast milk is enough, and formula, according to the actual instructions, is enough. Iron fortified formula, because you guys know your shit. All right, moving on. Any organ dysfunction. As the patient ages, we know that organ dysfunction can come with aging. We know that kidneys are not going to have the same glomerular filtration rate. When you become older, the glomerular filtration rate goes down naturally for older people. We know that because of that glomerular filtration rate, that we may have some issues with getting rid of water the way we used to. We also know that some patients have some cardiac issues, maybe even a previous history of an MI, which puts the patient at risk for heart failure. So what do we have? Maybe mild kidney failure, maybe a high risk for heart failure. And then of course, you know, because I did this video the other day, we have the alcohol issue and the fact that Americans seem to believe in their heart, and they were told wrongly so by professionals and experts. That's why it really matters that you keep learning and you keep doing your research, because we were told as Americans forever that a glass of alcohol a day is a good thing. No, the fuck it ain't. You might want to look at my video that I did about alcohol's effect on the body. It's really a bad thing for a lot of reasons. An occasional drink every blue moon is a great thing. I too indulge with, I'm kind of boring. I like coffee with Bailey's. Ooh, big time drinker, right? It just tastes really good. Nothing wrong with it. It's not a judgmental issue. It's a common sense issue that alcohol is a poison. And so if you continuously and regularly and methodically take in alcohol every single day, something's getting poisoned. And don't forget what I said in that video. I told you that alcohol was a carcinogen. It causes cancer. It's especially associated with cancer of the breast for women. Okay, so just come on, y'all, learn a little bit. But now, my point though is that if you have been told this and you actually thought that a drink a day keeps the doctor away, and maybe you do a drink a day and maybe more, yeah, your liver might not be as strong as someone else's, and that dysfunction could put you into the category of being at risk for overload, fluid volume overload. So I hope all that makes sense. So what did we say? Any kind of organ failure, right? So heart, kidney, liver, even your respiratory system. You know, ARDS, acute respiratory distress syndrome. Oh yeah, you're not getting rid of fluid. Hello, you've got edema, you've got crackles, you've got all of that. So, you know, boom, that's the thing. Select all. Now the causes, a little bit different than risk factors because it's much more specific. The causes of fluid volume overload, we're going to go into great detail about it, right? So let's look at the number one cause for the hospital admissions right now in any hospital you're going to work in. The number one reason is absolutely congestive heart failure. So here our heart, either the right or the left side, is not working the way it should. And remember how this whole heart thing works. The right side of your heart receives blood volume from all of your body. That is called venous return, because the right side of your heart is venous blood returning. And then this blood that returns through the right side of the heart, this venous return blood, is going to be sent to the lungs to drop off CO2 and pick up oxygen. That's going to happen in the alveoli of the heart. When it comes to the left side of the heart is arterial. So this side of the heart's job is to make sure it takes freshly oxygenated blood from the lungs and send it throughout the body, first through the aorta and every artery after that. And so that left side may have some dysfunction. And if there is dysfunction and the left side doesn't work and the patient has left-sided heart failure, the blood will not go out of the aorta through every artery into the body from the nose to the toes. It will not. It will back up. And if the blood fluid backs up on the left side, because the left side couldn't get it out, if that backs up, that fluid's going to back up into the lungs, right? So if there's heart failure on your left side, then that fluid and blood is going to back up into the lungs, and fluid and blood is called pink frothy sputum and pulmonary edema. See, you got this. Now, what if the right side of the body is failing? The right side of the heart is failing. So we know with the left side of the heart failing, we got crackles and lung issues. But what if the right side of the heart is failing? Well, then you're going to get a fluid volume overload there too. It's not going to be concentrated in the lungs. It's actually going to be concentrated throughout the entire body. And there's peripheral edema and very swollen ankles, and there can even be ascites, fluid in the peritoneal cavity. So it's just an example of showing you how these patients easily get into trouble. CKD, chronic kidney disease. We have stages of chronic kidney disease. Stage 1, 2, 3, 4, end stage, right? So end stage renal disease, RD, right? ESRD, end stage renal disease. That patient has a what? GFR less than 15. They require dialysis. They, being very personal to me, being my dad, who I took on a dialysis cruise recently. So he got his dialysis right on the ship. If you think about kidney failure, if we don't get his dialysis every Monday, Wednesday, and Friday, or for other people, Tuesday, Thursday, and Saturday, then his body's going to fill up with fluid and he's going to go into fluid volume overload. We even do something called dry weight. What is his weight right after dialysis? What is it right before? So that daily weights becomes 2 weights a day for dialysis days, right? So you know if the kidneys are failing, and the purpose of the kidneys is certainly fluid balance and getting fluid off the body and into the toilet, or off the body and into the potty, as my wonderful guy, Simple Nursing, Mark Lanier, I think his name is, he's wonderful, as he always says, off the body, into the potty. That's what you want to do when it comes to dialysis. And this person in kidney failure may have some issues as to why they're in fluid volume overload. And by the way, it doesn't have to be end stage renal disease. It could just be any stage renal disease, and then maybe the patient is getting too much fluids in the IV, for whatever reason. Perhaps they're being overloaded because they had surgery and an epidural or some anesthesia where we give you 500 cc's of fluid with that. It just depends. There's lots of reasons why the kidneys might turn the corner into trouble. You also want to remember this could be AKI. Now, chronic kidney disease takes 10, 15, 20 years to develop. AKI is acute. And for some reason or another, all of a sudden, your kidneys are not functional, and they can cause a very acute fluid volume overload, which is terrible because, nobody sees it coming. Maybe there's a pre-renal or an intrarenal or a post-renal attack or injury on the kidneys. And so, with pre-renal, you may remember pre-renal AKI or acute kidney injury had to do with low blood pressure. Intrarenal has to do with actual injury, maybe from some aminoglycosides like vancomycin. Post-renal means the urine just can't get out, okay? So you're kind of not able to get it out. And that could be from a prostate, it could be kidney stones, it could be whatever. But just know that this kidney issue could cause fluid volume overload. Oh, you know about cirrhosis just like I know about cirrhosis, but we're going to kind of tap into it a tiny little bit. With cirrhosis, there are scar tissue, fibrotic plaques, okay? Calcifications, hardening of that liver from the poison of alcohol. And when this patient gets so far gone that their liver is very, very much diseased, then the pressure in the liver is going to be increased, causing something called portal vein hypertension. The pressure in the liver. Let's talk about that. This is your liver. This is your heart. I hope you can see it. Okay, so the liver is on the right side. The heart is middle left. There is a vein called a hepatic vein connected to the heart, and there's a portal vein that connects to the intestines and GI system. When this liver gets diseased, everything backs up. And so when it's backing up, it's causing high pressure to fill the portal vein. And this portal vein is basically connecting the GI system. The liver also has a role to play with the protein that you eat. It takes the protein that you eat and it makes albumin. Albumin is a protein inside of the blood vessel that keeps fluid intravascularly balanced. So inside the vessel, intravascular fluid, albumin, it keeps the fluid in the vessel. But if your liver is diseased, it's not making albumin, fluid is easily leaking out of the vessel. Which vessel are we talking? The portal vein. So the pressure in the portal vein actually pushes this fluid, which is leaky, and pushes tons and tons and tons of fluid out into the peritoneal cavity, causing ascites. It's really bad, okay? All right. So that big, huge peritoneal cavity full of fluid is also going to block venous return, and this patient's ankles are going to be swollen and their body just looks terrible. They're so swollen, and we call that third spacing, okay? Swelling, edema, third spacing, we'll talk. Now, ARDS, of course, is a condition that usually, not always, is triggered by sepsis. And it's just basically causing the alveoli to collapse and not allow for gas exchange. The patient will be, no matter how much oxygen you give them, they will literally still have a pulse ox less than 90. That's the classic hallmark feature of ARDS. And they can't clear fluid, and they're getting to be very, very overloaded. This one, this endocrine disorder of SIADH, syndrome of inappropriate anti-diuretic hormone. Woo, that's a mouthful. Let me help you with this. SI, everything's high, okay? SI means everything is high. Everything, girl. So this SIADH, I want you to think of it as a neuro kind of issue, even though it's an endocrine, and it has to do with anti-diuretic hormone. So the patient with a SI or high anti-diuretic hormone, are they peeing or are they not peeing? Which one? High anti-diuretic hormone is not peeing. No, they're holding on to their fluid. They're having fluid retention, and it could be for any number of reasons. It could be a brain tumor. It could be brain surgery. It could be tuberculosis. It could be hyponatremia. It could be that one of these occurred, CHF, CKD, cirrhosis, and threw them into a hyponatremic situation. One thing you definitely want to take to your test is that SIADH means high ADH, and the other name for that is hyponatremia, because it's the sodium that's the only thing that's low. Everything else is high, right? It is. It really is. You'll see. Now, water intoxication is a form of SIADH, because if you drink so much water, and not just babies, grown-ups, if you drink so much water, you can literally dilute your sodium so that it's ineffective, and get yourself into this hyponatremia and SIADH. I want to show you something. I want you to think of these two containers. I love limoncello candles. They name them something else now. They should have just stuck with the original name. But I love limoncello candles. They smell really good. They hook up the whole classroom. So these are just two limoncello candle holders. They're the exact same. And I want you to think about it. If I put 1 teaspoon of sodium in this one, the container in my right hand, 1 teaspoon of salt or sodium, and I put 1 teaspoon of salt or sodium in this container, but I fill this one with water till it's overflowing, and I just put 1/4 cup of water in this one. You have to remember, the sodium was exactly the same in these two jars. What happened was the effects of sodium became incredibly diluted with all of this water, so that even though these two had the same amount of sodium, you already know which one's saltier. This one's saltier, and this one is very dilute. Well, that's what happens when we look at water intoxication leading to hyponatremia. You diluted the effects of sodium, and that's going to get you into a neurological nightmare, because when sodium is low, ICP, seizures, high blood pressure, headache, all the neuro symptoms come to play with these patients. So again, the sodium might have started out the same, but you overflowed it with water and now you diluted it. So this sodium coming back from the lab is going to look low because you diluted the shit out of it. I mean, you don't have an effective electrolyte here. And that's very important. So once again, in Cleveland, yes, in Cleveland, we literally had a radio station that had a water drinking contest. Now, this water drinking contest, yeah, the winner is dead. The winner died. Yeah, because of, here we go, water intoxication. So that was horrible. You know, that's like no knowledge on this stuff can kill somebody. So again, babies are at risk for water intoxication. If you water down their actual formula, that would be a horrible thing. And adults also can drink too much water. All right. Now, I want to remind you that this is the packet that we are in. And you know that all of my packets are available through PayHip. And if you look in here, of course, there is fluid volume excess. There's quite a few of those types of pages in here. There's also fluid volume deficit. There's a comparison of both, okay? So don't worry, you got the hookup. But also what I did in this packet is I put quite a bit of information about something very commonly on your test, which is the hyponatremia that we are talking about here. Okay, so you know, gotcha. Now, so this is called acid-base imbalance, but it's also fluid and electrolytes. Now, so moving on, you have a good handle on the select all that apply that goes with fluid volume excess, specifically causes. Let's move on in our select all that apply fluid volume excess and talk about complications that might result from a patient that is in a fluid volume overload. These complications, the number one complication that you'll have to know is pulmonary edema. Because of the backing up of fluid in the lungs, this is going to be a big respiratory nightmare. This is a medical emergency. They must be seen first. They're going to show you pink frothy sputum. There will absolutely be crackles, and it is very common for the kidney and the heart failure patient to get into trouble with that. They may never have had a history of heart failure, but the fluid volume overload in the elderly patient can lead to heart failure. That's kind of like how the kidney failure patient can also become a heart failure patient. We do see that. The seizures are very important because the fluid volume overload patient is most likely going to get into some complications with electrolyte dilution. And so if that's true, and the most common dilution that we see is hyponatremia, where the sodium is dilute, then yes, that turns into a big neurological nightmare, and seizures are definitely part of the deal. Seizures, brisk DTRs, clonus, things I've discussed with you before. Okay, but another one that people don't think about, because it's like not gonna kill you, but it's definitely a complication, is that this patient is so edematous. Sometimes it's so severe, it might be called anasarca. Anasarca means that you have an overwhelmingly outrageous edema throughout the body. You're like a Pillsbury Doughgirl. Your eyes are puffy. Everything is bad. Severe, outrageous edema all over the body. Skin breakdown is a complication from this situation, because just think of it. If you blow up a water balloon and you just keep blowing up this water balloon or filling up this balloon with water, if I go just like this, I could pop that balloon easily. Yeah, that's kind of how skin is. It will rip and tear and burst and all that stuff, because the skin is pulled so thinly and so taut, and it just easily tears, okay, or breaks down. Now, nurses, you know we had to bring it up your parking lot and down your street. What you gonna do about it, boo? Well, you're going to do a lot about it. You see this list? It's kind of big. So come on, y'all. Now, just like with the fluid volume deficit, we have to keep in our mind that some things don't change. So if you'll remember when I did the fluid volume deficit video, I talked about daily weights. Well, nothing's changed, okay? So of course, daily weights are going to be a big deal. Now, before I go into the fact that daily weights are your number one, intervention, I want to show you just the signs and symptoms on my chart that make sense to you if you looked at the other video that we did yesterday, the fluid volume deficit. In fact, excuse me, child, tired, hungry, something. But if you look at this chart, which is perfect for a case study, what I did was I left the same one up that I did yesterday, but you know that this video is all about this side. But let's point out some really important issues. Number one, the signs and symptoms of fluid volume deficit and fluid volume excess start out the same for two big things. Those things are the pulse and the respiratory rate. Both the pulse and the respiratory rate for both conditions are going to be high. It's just that with fluid volume excess, the blood pressure is also high. However, even though both patients have tachycardia, the quality of their pulse is very different. So watch this. Tachycardia, tachycardia. High respiratory rate, high respiratory rate. Now let's look at the quality of the pulse. The quality of the pulse for fluid volume deficit is weak and thready. The quality of the pulse for fluid volume excess is bounding. Very different. When I tell you something's weak and thready, I can barely find their vein because there's hardly any fluid in any of their vessels. This one, there's so much fluid in their vessels, it takes a lot of work on the heart to get that fluid through. Okay. Fluid volume deficit is a low blood pressure, and consequently the patient is dizzy. Oh, no. Fluid volume excess, the blood pressure is high because what controls blood pressure? Fluid volume. Yes, so the more volume of fluid in the body, the higher the blood pressure. What do we do when somebody's blood pressure drops? We give them a fluid bolus. This patient's got way more bolus than they need working around their little body, and their blood pressure's high. And then if you remember your neuro from your Oh My God packet, that pink Oh My God packet, you know on page 10 with neuro that neuro is all about high blood pressure and headache, and even visual disturbances. So add that to your list. So we have a high blood pressure. We have a headache. Matter of fact, I'm going to abbreviate this so I can put those visual disturbances in there, and you won't feel like I was cheating my babies, okay? So visual changes, huh? Now, so eyes doing funky things on you, all right? Now, as we move throughout the body, this patient with the fluid volume deficit, their jugular vein, their neck vein will be completely flat, especially when they lay down. You won't see anything here that's flat. This patient will have distended neck veins, JVD, jugular vein distension. So that is easy to see when they're laying down. Poor skin turgor for fluid volume deficit, edema for the patient with the fluid volume overload. I mean, you put your little finger in that ankle or that leg or calf or whatever, and you get a little well, right? That little well, like you pushed your finger there and you picked your finger up and it's still there. Yeah, that's pitting edema, okay? Then you see weight loss for fluid volume deficit, and we have something to make sure that you write down. 2.2 pounds equals a whole liter of fluid. So if the patient lost 2 pounds, they lost a liter of fluid for fluid volume deficit. The other thing to remember about that is your unit of measurement. 2.2 pounds is also 1 kilogram. 1 kilogram is 1 liter of fluid. 2.2 pounds is 1 liter of fluid. Now, over here, which is the subject that we're talking about the select all that apply on fluid volume excess. For fluid volume excess, this patient gains weight, and you know, there's a little bit, not much, a little tiny bit of a change on that issue. We've always been taught to teach the patient to call us with 3 pounds weight gain in a day, 5 pounds in a week. I want you to alter that just a teeny tiny bit, not much, not enough to make you fail this question. And that is that they need to call us even with a 2 to 3 pound weight gain in a day. And even, get this, with a 3 to 5 pound weight gain in a week. Notice that it said 5 back in the day. Now it's 3 to 5 in a week. Notice that it used to be 3 in a day. It's now 2 to 3 in a day. So 2 to 3 pounds weight gain in a day, call us. 3 to 5 pound weight gain in a week, call us. Essentially, what are you doing gaining weight? Okay, that's the bottom line. All right, in one day, you should not be gaining 2 to 3 pounds, like for real. Okay, now, fluid volume deficit. This patient has a high specific gravity, which shows up as dark urine. Typically, not 100%, but typically this patient shows up as low specific gravity and pale urine. Okay, not always. That may change. That part may be related to why they have the fluid volume overload. The red blood cells in their body, kind of going again with this issue, the red blood cells in their body, while the red blood cells didn't go anywhere, like they didn't hemorrhage, you added a ton of water in there with the red blood cells and you diluted them. In this case, the fluid volume overload patient or excess will have a low hemoglobin and hematocrit, and that will be called, and you need to know it, and I pray you are writing it, hemodilution. Over here, you have no water. So the red blood cells, the hematocrit and hemoglobin is going to be high, and it even puts you at risk for blood clots because it's sticky and it doesn't move very well and it's slow moving. It's sluggish, it's viscous, right? Remember that yesterday? Viscous blood. Now, this patient with fluid volume excess is going to have a low blood urea nitrogen. Just remember that blood urea nitrogen is waste products, and if you dilute them a lot with water, it looks like you don't have a lot. Again, low BUN. Seizures, high ICP. Let's add a little bit of more love here. Clonus, brisk DTRs are all part of the neurological nightmare that has to do with the fluid volume overload, if there's also electrolyte imbalance that goes with it. So in the patient that has a fluid volume overload, like that baby that had that watered down formula, that baby was seizing out at Metro Health Medical Center. Seizing makes sense. With the patient whose overload is also giving them an electrolyte imbalance, specifically hyponatremia, we can see seizures, we can see a high intracranial pressure, cerebral edema, write it down, cerebral edema. Whenever we have a neurological issue, we will have brisk, deep tendon reflexes. And brisk may be a word, but what if they use a number? So just think about it like this. Everybody in class that comes here every week they're normal. And we're going to say that if I were to go around and tap on all of their little kneecaps, I would get a 2+ reflexes. This patient with brisk DTRs is 4+, like seriously 4+. Outrageous. Whenever there is 4+ or brisk deep tendon reflexes, there will also be something called clonus. And clonus is where you grab the bottom of the feet, dorsiflex, or put the toes to the nose, let go, and the foot taps you back. So pretend this is my feet. Pretend I'm going to assess for clonus. I'm going to wrap my hand around the bottom sole of the feet, dorsiflex the toes to the nose, let go. Clonus is when you keep tapping me back with your foot, okay? So that's clonus. This patient over here, the fluid volume deficit, is positive orthostatics and postural hypotension, which we talked about yesterday. If they get out of the bed too fast, they're going to faint. My dad's done it. They're going to just fall out. They're going to get lightheaded, dizzy, and be like, bye. And it's usually his blood pressure right after dialysis. Why? Because they remove so much fluid. Hey! So they may not need to remove as much fluid and he will feel better. All right, now, here, under fluid volume excess, crackles in the lungs, pulmonary edema. I already told you that's pink frothy sputum. Shortness of breath and dyspnea goes with the condition, absolutely. These patients have fluid all around their body. It's hard to get that off. It requires you working extra hard to even do anything. So you're short of breath and you have dyspnea. This patient over here with the fluid volume deficit may experience constipation and definitely will experience thirst. This patient has cool, pale skin and may be restless. This patient has warm, dry skin, and confusion may be part of their deal. Over here with the fluid volume overload or fluid volume excess, there's a type of hemodynamic monitoring called central venous pressure. Their central venous pressure will be high. And I tell you to think of central venous pressure or CVP as central volume pressure because it's measuring the venous return or volume of blood returning to the body, and it will be high with the patient with an overload, okay? If it's a baby, they're gonna have bulging fontanelles, and that's ugly. If it's over here and it's a baby, sunken fontanelles with no tears. So fluid volume deficit babies, they don't make tears. And of course, lips are cracked and their saliva's really sticky and okay, now look at this. We got to get this patient treated. We talked about the most important intervention of all nurses is going to be daily weight, same time, every morning, preferably without the clothing, but in a hospital, a gown is fine. Before they go eat, but after they go pee. Okay, you got it? Same scale. All right. I use this opportunity to teach my patients that you ain't going home unless you can prove you got a scale at that house. All right. Now, 2 to 3 pounds, that reflects the new guidelines. 2 to 3 pounds a day, 3 to 5 pounds a week, we teach our patients to report. New guidelines. Not much change there, but enough where you could get into trouble. Okay, so we want to make sure you knew that. Your job, nurses, is also going to be to prepare to give diuretics. Now, what kind of diuretics? Loop diuretics. Now, you got to be careful, right? You got to be careful. Hold on one damn minute, okay? When you give loop diuretics, bumetanide, torsemide, furosemide, don't get stuck on furosemide. It might be torsemide or bumetanide. Honey, they got enough out there to confuse you. So if you're preparing to give this loop diuretic IV push, you must give it super slow or you're going to cause tinnitus and deafness. And I've seen it. You must know that anything you give IV push should be given over 2 to 6 minutes, super slow, unless it's a adenosine slam, then it's really fast, okay? But this is freaking torsemide, bumetanide, furosemide, loop diuretics, and you're going to give it quite a bit. Your career is going to be given this. Of course, our LPNs are not giving this, so when our LPN has a patient that has any of this going on, they'll pass the PO meds, they'll come and get us to do the IV push. Dialysis might be needed, PRN. We do have patients that have the kidney failure or the end-stage renal disease, and they think it's a great idea to miss a dialysis appointment. Now, you know my daddy ain't that one. My daddy know I will break his neck on purpose in little tiny pieces and pray about it later if he even thought about missing a dialysis appointment, because that's dangerous. Your little ass can die. I lost a crazy-ass cousin. Now, he was an alcoholic, but he died because he missed his dialysis appointment. So that shit is serious, okay? So we might need to get that fluid up off of you real fast. And if it's a kidney failure issue, this will be how we do it. All right, now IV fluids in this case, while we will go slow and we will go low, the type of IV fluids might not just be the clear solutions, but might include something called colloids. Remember, the crystalloids are see-through IV fluids. Colloids are not. The number one colloid that I might need to give to help this patient's fluid imbalance is albumin, so that we can keep, this goes back to the liver disease, so that we can keep the fluid inside of the blood vessel and not in the interstitial spaces, which is called edema. I want to make sure that you remember a little something about this whole thing. So we have something called extracellular fluid, and we have something called intracellular fluid. Extracellular fluid is 1/3 of the body's fluid, and intracellular fluid is 2/3. Extracellular fluid is plasma, which is another name for intravascular fluid, and what we call interstitial fluid. Interstitial, I teach you guys to say interstitial in the tissue, interstitial in the tissue, interstitial in the tissue. Okay, so think about it. We have inside the cell itself, every cell, that's the intracellular fluid, and the intracellular electrolyte is potassium. The extracellular fluid is all the other fluid in the body. That's all you got to remember. And that could be in different areas. It could be right inside the blood vessel, which makes it plasma and intravascular. Or it could be outside of the blood vessel and just in the body or in the tissue, and that's interstitial. When we see pitting edema, that fluid has made it to the interstitial area. It's not in the other areas. That's important. Now, so our albumin that we give the patient will keep the fluid intravascular or in the plasma and not swelling and edematous in the ankles. All right. Now, sodium and water restriction. Let's talk about that, shall we? When you put your patient on a sodium restriction, the best advice I can give you to give them, this is patient teaching basic care and comfort, y'all. You need to make sure you tell them to read all labels, because there are lots of different foods that have hidden sodium. Bread is one of them. So read all labels. Bread is a hidden sodium. Water restriction, sometimes. I do it occasionally. It is like down on the list. It's the last resort. You got to be pretty sick to get a fluid restriction, but it's important. Keep the head of the bed up in semi or high Fowlers. Remember, this patient is having respiratory difficulty, and keeping the head of the bed up will help them. Immaculate skin care, meaning turn the patient every 2 hours. You probably need telemetry if it's a cardiac issue or electrolyte issue. And then lastly, you need to monitor very closely the sodium and the potassium levels, because if there is true fluid volume overload, it could throw the patient into a hyponatremic situation where the sodium is dilute. Now, I hope that this helps you. Remember, we have a 3-day boot camp coming up in Cleveland, Ohio. That's on January 17th, January 18th, and January 19th. Remember that 3-day Friday, Saturday, Sunday comes around every 6 weeks or so. The next dates that you can plan for is February 28th, March 1st, and 2nd. I'm excited. I can't wait to see you. I kind of missed your little ugly asses because like the holidays have been, pretty exciting, but I love teaching and I absolutely adore students. Happy New Year! It's a new year! Get rid of the old shit. Deuces.